This episode of UK Low Carb Podcast is sponsored by Deliciously Guilt-Free. Enjoy the show. Today on the Low Carb Podcast, I'm welcoming Lily Nichols, who I'm incredibly excited to be meeting for the first time face-to-face, although we have known each other for a while. And the reason for that will become apparent as we continue talking. So Lily is a dietitian. She's a registered dietitian in the United States. She is the author of Real Food for Pregnancy and Real Food for Gestational Diabetes, and is a certified diabetes educator. And she's highly sought after for her expertise on real food or low carb in pregnancy. So Lily, thank you so much for joining us today. Really excited to have you here. And I have to say, I told a few of my low-carb friends, women in this group that I'm in, that I was going to be speaking to you, and some of them are pregnant. And we all had kind of like a fangirl moment where we all got very excited about the fact that I was going to be asking you some questions and, and getting to meet you because, you really have had such a massive influence on the pregnancy community, and people who have a low-carb lifestyle. So thank you so much for joining us today. Really excited.
Thank you for that. And I'm excited to finally meet you face to face virtually as well.
Yeah, no, it's absolutely lovely. And it kind of blows my mind. I know this might seem really basic, but the fact that you're on the other side of the world and it's lunchtime where you are, and I'm going to be getting ready to go to bed soon, just absolutely blows my mind. So I hope you don't mind. I thought I might ask you just a little bit about yourself, if you wouldn't mind just sort of like, telling me a bit about how you ended up doing what you do, maybe a little bit about, where you grew up and where you live now, if that's okay.
Sure. Yeah. So my work as a dietitian has mostly been in the prenatal nutrition space. And that has ranged from clinical work, one-on-one work with clients, to public policy work. That's really how I got heavily involved in gestational diabetes work, was with the California Diabetes and Pregnancy Program, which many people know as Sweet Success for short, and also in consulting, research, just basically any capacity that you can work in the prenatal space. I have worked, and in all of those areas, it just became apparent to me that the guidelines are not necessarily based on the most up-to-date evidence. They don't always work in all clinical cases. And this definitely became apparent to me in my clinical work with gestational diabetes, because like a good dietitian, I followed the guidelines. And so I'd put my clients or patients, whoever is coming to see me, on the conventional diet, which happens to be relatively high in carbohydrates. But, I was trusting that there was good evidence behind these guidelines, but what happened really surprised me. I mean, people's blood sugar often got worse, and I was just seeing astronomically high rates of requiring insulin and medication, when I really questioned if we had more wiggle room in going lower carb than what the guidelines were. And that is what ultimately kind of got me really fired up about this whole thing, and really deep into the research to uncover, how are the guidelines for prenatal nutrition set? Are they based on solid evidence or not? Is there room for improvement? And ultimately with gestational diabetes especially, there's a lot of room for improvement. And I wanted to get this information out in a bigger way, which is why I originally came out with Real Food for Gestational Diabetes in 2015, and also my online course, which I've had the pleasure of supporting you through your pregnancy in that course as well, because I saw that we really needed to get this information out kind of on a grassroots level, because it wasn't going to work from like a top-down policy level. I worked enough in public policy to understand that there's a lot of bureaucratic roadblocks to pushing for change. And so I knew we needed to kind of do it from the bottom up. And ultimately it's been really exciting to support women on having healthier pregnancies, to see some guidelines shift. Like the Czech Republic has updated their gestational diabetes guidelines for their whole country, and they've dropped the mandatory minimum requirement of carbohydrates and instead put in a max cap, which is interesting.
Incredible.
And I'm hopeful that we'll see more change in other countries as well.
So just to go back a step, so you talked about obviously, being a registered dietitian. So where did you study dietetics?
Oh, yeah, I studied dietetics at University of Massachusetts, and then I did my dietetic internship at USC, University of Southern California, in the LA County Medical
Fantastic.
Center.
And when
Yeah.
you were studying, what was the dogma there? What sort of, in regards to carbs, what was your course kind of directing you to do as a practitioner when you graduated?
Well, I mean, any dietetics training is going to teach the guidelines. And so the guidelines are 45 to 65% of your calories coming from carbohydrates. This remains true for pregnancy.
Mm-hmm.
And for gestational diabetes, they additionally recommend that you not go below 175 grams of carbohydrates per day.
Right. Okay. And then just you mentioned that so after you graduated, did you go straight into working with pregnant women, or did you mentioned you did an internship?
You do an internship first in order to become a registered dietitian. So that's about a year long. So that's the one at LA County USC Medical Center. I did see gestational diabetes while I was there, but not a lot because it was inpatient gestational diabetes work. So those are people who have been, for people who don't know, inpatient means like admitted into the hospital. So somebody who's having complications and is like in a hospital bed, right? So there was a little bit of gestational diabetes there. And it was, of course, as with any of the diabetes you see clinically in the hospital, really weird because it's like they're always trying to hit a minimum amount of carbohydrates. And it was like, why are we giving them a whole bunch of carbs when they have a blood sugar issue? What? But I started seeing gestational diabetes a lot more when I worked with the California Diabetes and Pregnancy Program and also clinically. So I was the sole dietitian for a perinatologist, so like a high-risk obstetrician who had specialized in gestational diabetes pretty much for most of her career. So for that area of LA, we saw almost every other provider would refer to us if they had a client with gestational diabetes. And so I was responsible for teaching the gestational diabetes class, for all the individual management. It was very fortunate that this practitioner and the whole practice was very nutrition forward. And so they really let me decide a lot of things. I mean, it was like the doctor sat me down when she hired me for the job and was like, you're responsible for their blood sugar, for their management. You're the one who decides if they go on insulin or medication.
Wow.
Which is like a big responsibility to put on a dietitian. Of course, they're available to consult, but they're like, we know we can do a lot with food. And I want you to do as much as you can with food before we go to medication. They
That's
also
incredibly
gave me the green
progressive,
light.
Really, isn't it?
Really progressive, actually. Yeah. And they also gave me the green light to like completely revamp their nutrition program, to completely redo their educational handouts. They're very open to research. I mean, we're associated with a teaching hospital. We had residents coming in. She was the chief of perinatology at that hospital specifically. And so when you have people who are like research focused and like work in teaching hospitals, they're more open to change maybe than people who have been, doing the same old for 40 years.
So presumably when you started working with these women, initially you were using the guidelines to manage them.
Oh yeah, because everything that I had been taught up to that point was that's what you do.
Yeah, of
and
course.
I was being a good little dietitian,
And how long was it before you started to say, does anyone see what I see here? Like, this isn't working very well. How long did that take?
Yeah, not long, like months. Within months, I was changing things. But yeah, I would go home every night from my job and research. I connected with a lot of other practitioners, some really forward-thinking clinicians like Dr. Jovanovic, which everybody knows for being really a champion for low carb in pregnancy. She was involved with the California Diabetes and Pregnancy Program as well. So we kind of worked, not together because she was in another part of the state, but we worked in the same organization. And when I heard that she was doing lower carb than the guidelines, I was like, whoa, okay, there's something to this.
Yeah.
And there is a lot of practitioners who were sort of like secretly doing low carb, but they wouldn't talk about it because the guidelines said you got to do a minimum of 175. But you'd sort of hear through the cracks, like, well, we went down to 150 grams of carbs. Well, we dropped, the bread from the meals. And so it was like this sort of
fascinating
like underground. Yeah.
To have this stigma over, not eating or just slightly reducing these foods that have become such an accepted part of our diet. It makes you wonder really about what's going on here, that people feel like they'll do something, but then they have to be secretive about it.
Well, dietitians are very, very risk averse. People don't like to go against the guidelines.
And do you know why that is? I mean, is it the way you're regulated, or, are there repercussions? Have people had, difficulties with their employers if they go off-piste?
Yes. Yes, they have. So you can, you could lose your job if you go against the guidelines. You could be reported by other dietitians. I feel like dietitians are some of the most, they get really upset when others in the profession aren't following the guidelines. And so you could get reported by somebody. In my case, I was given the go-ahead by the medical director and doctor of the facility to do different. So I kind of had permission basically to do different. But also I didn't like change what I was doing right away. I had to research it quite a bit I wanted to make sure I wasn't doing harm, right? So I was researching about ketosis in pregnancy and what physiologically happens or what doesn't happen or what could be the potential harm. I was doing micronutrient analyses of different meal plans to make sure we weren't going too low in any nutrients, because there's all these fears.
Yeah, of course.
If you do different, you're going to create a problem, and you don't want to, especially in pregnancy when I feel like it's such a high stakes thing. It's not just the one person's health, it's the baby as well. So I was doing a lot of research to make sure that what I was doing was safe. It was pretty obvious that it was going to be effective, right? If somebody has carbohydrate intolerance, aka some form of diabetes, like, you reduce carbohydrates and you're going to result in better blood sugar. But I had to make sure that it was going to be safe, especially for the baby, and safe for meeting micronutrient requirements and all of that.
Yeah. And, and it seems fairly intuitive once you think about it, and especially when you phrase it like that, that a carbohydrate intolerant, state might be, better off not throwing carbohydrates into the system, and yet the current guidelines as they stand don't really, still to this day recognize that. One other thing I wanted to ask about, so you had the support of your employer. Were you ever concerned that your regulatory body might have problems with what you were doing?
I mean, not clinically, not at that time. I was certainly fearful when I went to publish Real Food for Gestational Diabetes. Yeah. Because it was nobody bucks the system with prenatal nutrition. Nobody. And nobody tries to do different with gestational diabetes.
No, they don't.
So I was kind of like, I was treading on, sacred ground, I guess you could say. Yeah. So I was nervous that I would get a lot of pushback. And that's why, both of my books, probably even more so Real Food for Pregnancy, are just really heavily cited. So that when people are like, well, where did you just come up with this? You just pull this stuff out of thin air? I could refer them to the scientific sources. And a lot of times it's like, we don't have perfect answers on everything. We don't have perfect research on everything, but that doesn't just apply to people who are, suggesting something different. That also applies to the guidelines. A lot of the guidelines are not based on strong evidence at all.
Pretty much. Some of them are So this, let's take the example of the minimum carbohydrate requirement for pregnancy. Just I think I remember reading that in your book, but just run me through, like, did anybody ever manage to find the evidence or the so-called evidence for that?
I did, actually. It's in the Institute of Medicine has it's like a 1,300 page document on nutrient requirements. I think that one's specific to macronutrients. And there's a section on carbohydrates and a section on pregnancy. And they walk you through how they came up with that number. It's a little convoluted, but you can put it together when you read that. And essentially they start with an estimated average requirement of carbohydrates for a non-pregnant person, which is assumed to be 100 grams. And then they add on additional carbohydrate to account for the glucose requirements of the fetal brain. So how much glucose is the fetal brain pulling from mother on a daily basis? They don't consider that could be coming from endogenous sources in the mom, right? That's from outside. And even that estimate, you read research and it varies. So they chose one random number to go with on that. And then they add in additional carbohydrate to account for the increased energy demand of pregnancy. So if we assume there's going to be an extra 300 to 500 calories per day required, and you're going to be getting approximately 45 to 65% of those calories from carbohydrates, they calculate that out and add it in. And there's some rough numbers around there, but they seem to round up to 175 grams.
And the original, and the first thing that you mentioned there was that they took the minimum carbohydrate requirement for an adult.
Estimated average carbohydrate requirement for an adult, yes, of 100 grams.
Of 100 grams. Now, where does that come from? Because is there such a thing as an essential carbohydrate?
Well, when you read in the Institute of Medicine document, they contradict themselves all over the place, because they do point out that there is no, minimum requirement of carbohydrates, assuming that a person is eating adequate calories from protein and fat. In other words, gluconeogenesis happens. Your body can create glucose from fat and protein. And so you're not going to die if you don't eat carbohydrates, but you will die if you don't eat fat and protein, right? So there are a lot of contradictions in there. And you tend to see a lot of that when you start digging into almost any guidelines, but it was especially clear on the carbohydrates and pregnancy.
Yeah. So this is the same document that says that you can survive on fat and protein, then says, okay, so we need 100 grams a day of carbohydrate in the same document. So pretty contradictory. And then, this figure for pregnancy has been, people have almost forgotten where it comes from, because people just cite the last paper that said it, and then they cite another paper, and you've just gone on this massive trail and found this original, this is where it came from, slightly plucked out of the air.
It was pretty shocking to uncover that, and also pretty frustrating to have worked in sort of like a public policy position and to not have had any of my other colleagues question this stuff. It's like, some of you guys have been working in this field for 30 years and I'm the young dietitian coming in here. So I'd like to think that I can trust the precedent that's been set, but nobody could tell me where the 175 gram figure came from. It was almost like, why are you even asking? Why are you even questioning this? That's the requirement.
I do find it fascinating because, as you know, I'm also, I'm a medical practitioner. It's worth me mentioning at this point my medical disclaimer that I am not an endocrinologist, I'm not a diabetologist, I'm not an obstetrician, but I am a doctor who happens to have an interest in low carb, and I've had a couple of gestational diabetes pregnancies myself. But one thing, just as a general observation, it's quite possible to work as a medical practitioner just following the protocols blindly and actually, have a great career treating people and never really digging into the evidence behind things and, or going back to the primary sources to think for yourself. But I believe actually that having gestational diabetes and then kind of making my own mind up about how I wanted to eat in my pregnancy was a kind of a massive turning point for me personally, because I'd always been the sort of person. I actually cringe now when I think, because I remember seeing patients in clinic, and sometimes they would mention to me a supplement or or a way of eating. They may have even asked me about low carb. And I remember being very dismissive and sort of saying, oh, well, I don't know about that, but the reason I don't know about it is because if it was truly effective, then it would be national guidance. And that now makes me so embarrassed. Now, if somebody came to me in clinic, in the future when I'm back to clinical work and asked me the same question, I wouldn't be able to necessarily endorse anything in particular that wasn't guidance, probably for the same reasons that we've talked about earlier about,
right.
You have to be extremely careful about the advice that, that you give to patients. It has to be evidence-based. And if I haven't personally reviewed the evidence, then I wouldn't be able to give my opinion on it. But I just feel like in my tone, I would be so much less dismissive nowadays that we know but little, actually.
Right.
And there is a lot out there, that we are still yet to discover. So that's one thing that I think, of this experience has kind of changed the way that I would do things in the future. Because up until that point, I was so happy to just, I'd arrive in a new clinic, I'd be like, give me the flow sheet, tell me what we do here.
Right. And also, as clinicians, we're really, really busy, right? It's not like you have time in clinic to be reading research studies. You rely on those guidelines, or you rely on the research of other people. And that's a tough thing. We can't expect like a GP to be reading, 30 studies on gestational diabetes. They're going to do what the national organization tells them to do. And you should be able to trust that information. You know what I mean? Yeah. So it's kind of frustrating on a systemic level too.
It is frustrating. And, we'll talk about it, as it goes on. And, hopefully there will be incremental changes, in that, and maybe a bit of a movement in the medical profession to demand change as well. But yeah, no, you're absolutely right, which actually makes it even more incredible that you had this busy practice during the day, and then by night you were reviewing the evidence and sort of making your own mind up, and I'm so glad you did, because I have to say, when I was diagnosed with gestational diabetes the first time, I went onto the internet to try and find guidance, to try and find somebody to talk to about low carb and pregnancy, and I couldn't find anything. And there was nobody. And I even asked on Twitter, and I said, does anybody know a low carb dietitian that I can speak to about my gestational diabetes pregnancy? And the most I got from the UK was one name, but they weren't open to speaking to anyone. They didn't have that kind of practice. Mm-hmm. And that's how I ended up actually finding you, because I had to go to the States to find somebody who was willing to talk about this.
And I'm connected to a lot of, there are many low carb dietitians who have come before me. And I talked to as many of them as I could when I was doing this gestational diabetes thing. And like, am I crazy to think that we could be going lower carb here? And because none of them specialized in prenatal nutrition, it was sort of like, don't touch pregnancy with a 10-foot pole, because there's too much that we don't know. And the stakes are too high. Like, they didn't want to do it. They didn't want to talk to me about it either. So talk about feeling like, oh gosh, what do we do here?
Yeah. You're kind of, I guess, out on a limb, but with this thing that you really believe in. And I just wanted to touch on as well, I don't know a lot of detail about the case, but then the Tim Noakes case, which if I've got the gist of the story correct, centered around advice on what to give a child, or what to give a baby,
something like that. Yeah.
And obviously that ended up in I believe he was being pursued by his regulatory body in South Africa. And I just wonder if cases like that would, also have an impact on the psyche of practitioners like yourself, where you just, or maybe not.
No, it does. And again, that's why I cite everything. And that's why, everyone's going to come at you from all sides with their criticism, and they always do. I just got an email today from a dietitian who disagrees with me, and that's fine. It's part of the reason that my recommendations, my book and you have my course, so like the carb recommendations, they're really not that low carb, right? So 175 grams is the minimum they come out with in the guidelines. Like I have a range that I recommend, but the upper tier of that range is 150 grams. It's not, it's like 25 grams less. It's not that much. Moreover, you're not going to, you have to make sure that you're meeting all the micronutrient requirements of pregnancy, which you are. And in fact, you actually often exceed those your micronutrient intake when you're eating more real food. So it's not just about like arbitrarily cutting carbs and not doing anything else. It's about replacing it with real food.
I had never felt like I was so well nourished as when I was eating for that pregnancy, because I felt like I was just having such a range of foods, and and suddenly when you are cutting back on things like bread and potatoes, you have just so many other options, full of vitamins that you can be eating.
Exactly. And all it takes is running a quick micronutrient analysis, So it's like, run the micronutrient analysis. You got to consider what other cultures do. There's many cultures that eat lower carbohydrate amounts than our Western guidelines tell us, and that our Western countries do. And also for me, it's like just citing everything. Like, here is the research. You can come to your own conclusion. If you disagree with me, then please write your own book, cite everything, and give me all the rationale for doing what you're doing. Because what I read from the guidelines is not that evidence-based. They'll call it evidence-based, but there's really not hard science to back 45 to 65% of our calories coming from carbohydrates. Like, who decided that's a good idea? Just in 2015, they did the first ever study that directly measured protein requirements in pregnant women. 2015, that was the first ever study measuring protein requirements in pregnant women. And guess what they found? The guidelines are way off. They're 73% too low for late pregnancy. But
that's incredible.
Here we've been going by the guidelines for all of these years. And it's like, when new evidence comes out, we have to do better. That's all I can say.
Absolutely. And I without wanting to sound too much like a fangirl, I just think it's so incredible that you have put this out there to the world, and it is an extremely heavily cited book. And that was the great thing about it, because, whenever I would go to clinic and I would be questioned about what I was eating, I would just in the back of my mind, I was like, I'm going to pull out some facts from the book, to support what I'm saying. So
the proof is in the clinical outcomes though, too, right? Like we can get all like, give me the research, but also like, how do you feel? How's your pregnancy progressing? What's the pregnancy outcomes, birth outcomes, baby's birth weight, rates of neonatal hypoglycemia, or all that stuff? It's like the results also kind of speak for themselves in that way as well.
So just to go back a little step, for those who don't know, or who maybe just today have had the phone calls, informing them that they have gestational diabetes, would you be able to explain sort of in a layperson's terms what that means?
Yep. So gestational diabetes is elevated blood sugar that's either first recognized or first develops during pregnancy. That's really it. Another way, though, to define it is carbohydrate intolerance in pregnancy, which means your body is unable to process large quantities of carbohydrates at a time without experiencing high blood sugar.
Which may explain why, having gone to the hospital for my glucose test, which I was invited to do because of my family history of diabetes, so obviously I went in fasting, and I drank the glucose drink. Then I went to the hospital canteen to have breakfast because I hadn't, eaten yet.
Oh man.
Obviously, there was white bread involved in that.
Wait, you had this before you had your follow-up blood draw?
No, sorry.
Okay.
Sorry.
Okay. After
well, actually,
okay.
This was afterwards. Oh, that would have been bad. Yeah, you're probably right. Are you sure you had it? Maybe you were misdiagnosed. No. This was to celebrate afterwards. I had breakfast because in my mind I was like, all I had for breakfast was a glucose drink. I need to eat food now. I'm pregnant and I need to nourish my baby. So I went to the canteen and I had some white bread and eggs. Then I rolled back home because I walked back home. By the time I got home, I felt so ill. I was lying on the sofa, sleeping all afternoon, when I then had a phone call from the hospital. And, to be honest, feeling so tired after the test, I was like, I'm not sure this is going to go my way, this result. So, but I still remember very well, that feeling of shock when I got the phone call. And I think for a lot of women, getting a diagnosis of gestational diabetes, it may actually be the first time that they've ever been told that there was something off with their health.
Right.
And do you ever hear that from the people who do your course at all about, their initial feelings about being diagnosed?
Oh, all the time. I mean, the way that the book, if I go back to Real Food for Gestational Diabetes, the way that is written is very much informed by my clinical experience, because every time I would come in for that initial, we had a class, it was a gestational diabetes class, there was usually a couple people in the class, and whenever we'd have that class, it was like everybody needed to sort of like decompress over how they were feeling about the diagnosis. In fact, that's often what I would come in and saying, like, how are you feeling about this? Because there's a lot to unpack there, and it's really stressful. And I feel like a lot of the way that our health system approaches gestational diabetes is very fear-based. It's like they want to scare you into doing the right thing. They want to scare you into good blood sugar control, which I don't think ever works all that well. It's always like, well, here's the ultimatum. If you don't do XYZ, then all these terrible outcomes. And that doesn't help anybody, first of all. I think it's important to have, informed consent. Yeah, of course, we need to take the diagnosis seriously. But I really try to take it from an empowering stance, because if you are able to maintain blood sugars in the normal range, for the most part, I mean, some transgressions are not a big deal, then you don't have higher risks of all these terrible outcomes. And that's important for people to know, that you can still have a healthy pregnancy despite this diagnosis. And in fact, some people will have healthier pregnancies as a result, because it really makes you prioritize your health and what you're eating more so, because you're keeping constant tabs on it by checking your blood sugar every day.
Oh, and it is like a full-time job, isn't it? Having a pregnancy with gestational diabetes, and it's very intensive, which we'll obviously come on to a bit later. And what if the people, do you ever come across people who are in denial about the result of the test? Can you tell me a bit more about that?
Yeah. So, I mean, the funny part about when you branch out from conventional healthcare and go, private practice, or, I have this online course, the people who seek you out are the highly motivated people. And when you're in clinic, you have a whole range, the whole spectrum. You have a lot of people who's like, well, the doctor said I need to see the dietitian, but I'm not really, they come in with their like giant soda and donut, for their session. So you do definitely see that as well. And again, I still don't think scaring them into doing the work is important. I think we can still communicate the information in a way that's not fear-mongering. But I have had a fair amount of cases where I did need to sort of have a heart-to-heart. We'd have I try to keep it real upbeat at the beginning, and motivational, and we, get through the class, and they'd come back for several follow-ups. And sometimes it gets to the point where it's like, I can tell the person isn't actually doing the work. Blood sugar doesn't lie, the person who's really motivated and is coming in with consistently the same blood sugar readings, the same high blood sugar readings every time, they're worried about it, and you're talking about it and you're figuring it out. If we haven't figured it out in a couple visits, then I can tell that there's something going on there. And a lot of it is psychological. You know, you have to do a lot of motivational interviewing and sort of unpack what is happening. But yeah, there are some people who, yes, they're in denial. Some of them, I think maybe they're not really all that interested in making health changes, or there's some barrier there we haven't identified. And then I think a very small percentage, but it still exists, believes that gestational diabetes is a made-up diagnosis, and they don't think it's real.
And that's
there
why
are some people.
I came across that,
Yes,
quite a bit. Not so much in the people doing your course, obviously, because they were a very self-selected, very motivated group.
Exactly.
But in other Facebook groups that I was in at the time, I'd noticed that people would join and they'd be like, well, is this even a thing? You know, the medical profession is trying to label me as ill and I'm not.
Exactly. So I think some of it comes down to sort of like the more natural leaning people, and like, full disclosure, I identify as one of those people. Okay. So I'm all about like low intervention pregnancy and births as natural as possible. However, I think there has been some maybe misinformation communicated within that community about blood sugar in pregnancy, and they don't realize that blood sugar values actually are meant to be lower in pregnancy. They're not meant to be higher. So some people, especially like in the midwifery community, like I had a table at a midwifery conference several years ago, and I had some really angry people coming up to talk, like, who are you here talking about gestational diabetes? This doesn't exist. This is a creation of the conventional medicine model to label pregnant women as high risk, force them into inductions and C-sections, and da-da-da-da-da-da-da. And I will agree that it's unfortunate many times our conventional model does force people into unnecessary interventions because of this label. However, it's not a made-up label. It is a legitimate phenomenon.
Yeah.
And blood sugar levels are not naturally higher in pregnancy. Blood sugar levels are naturally 20% lower in pregnancy. So if you are indeed seeing post-meal blood sugars in the 150s and 160s and 170s, or seeing, results from a glucose tolerance test that are in diabetic levels, you do need to take it seriously. And that's the part where it's like, it's a nuanced discussion. It's not as black and white as either of the communities would like to make it seem.
Yeah. And, while we're talking about diagnosis, just with a slightly kind of UK/European perspective on it, I don't know if you've come across this, but I believe this is still going on, that in some hospitals in Ireland, when you're diagnosed with gestational diabetes, or if it's suspected, then instead of being given a monitor to use at home, they bring the women in for breakfast and give them cereal and then measure their blood sugar afterwards. I know this sounds made up, but
we like on a regular basis.
Like several times a week. So they won't give them a blood sugar monitor.
What?
Yeah. And then if they get high blood sugars after having cereal and porridge and toast, then they put them on treatment.
Oh, wow. Bizarre.
You've not come across this?
No, I haven't heard of that.
I'm going to have to fact check this. So at some point, I'm hoping to also on this podcast interview a really incredible lady who set up a huge Facebook group in the UK, and there are a lot of Irish women on there as well. And so it's their experiences that, we were coming across, because some of them were actually going on to the group to say, has anybody got leftover strips? Because they weren't given any strips, they weren't allowed to monitor. This was the way they were diagnosed and managed, come in and eat carbs. So I was just fascinated to know if you'd heard about this.
Gosh, I have not. That is fascinating horrifying.
I am going to have to find some more concrete details and send them to you if you'd be interested to know.
Yeah, definitely.
But apparently that goes on. So I should really count myself lucky to have been diagnosed on the glucose test. So just on the subject now of monitoring, so I'm kind of moving through the diagnosis journey. So, we've had the phone call and all the emotions that come with that and the diagnosis. So what can someone expect after they've been diagnosed with gestational diabetes? The first time that they go for that appointment in the hospital, what's likely to be included there?
Well, now that you've told me about what happens in Ireland, I don't know if I can speak for what happens globally. I can
see you're very shocked.
Now that it almost sounds like they're trying to confirm the diagnosis by giving them a repeat meal, a high carb meal, to sort of replicate the glucose tolerance test in real life in the hospital. Yeah. That's sort of what it sounds like.
My understanding of it was that they were trying to replicate it in real life and also trying to almost demonstrate. It's almost like they've decided that a bowl of cereal is what a pregnant woman should be eating at a meal, and therefore they would give them that test, and then if they couldn't manage it, then they would have to start treatment. That was my understanding. But
it's bizarre. There must be some details missing, because this doesn't make any sense to me.
No, it doesn't. And I'm gonna find out more, and I will follow up and let you know.
Yeah. So in the US, what I could say, and it'll vary depending on where you live, but best case scenario, you'll get diagnosed and then you will meet with somebody to discuss the diagnosis and your treatment plan. So it might be a dietitian or a diabetes educator, a nurse, your doctor. And it depends on where you're at and how high quality that information is or not, but you might be given, a blood sugar meter and test strips, and then instructed on how to use your glucometer, how often to check, what the reference values are for your blood sugar, in the normal range or outside of the normal range. You might be given a meal plan or instructions on how to count your carbohydrates or put together meals that would hopefully manage your blood sugar well.
Yeah.
Again, it'll depend on where you are, how high quality that evidence is, or that they're giving you, right? So most of the time it's going to be following the guidelines. So you'll probably be instructed to have several portions of carbohydrates at every meal. There tends to be a focus on consistent carbohydrates. So like a consistent quantity of carbohydrates, meal to meal, snack to snack. This is where your blood sugar should be, and then come back and see me, hopefully, to discuss what you observe.
Yeah. Okay. And how often might they need to test their blood sugar?
Typically 4 times a day is the best recommendation. So fasting blood sugar first thing in the morning before you've had anything to eat or drink other than water, and then after meals. And depending on what practice you're at, it'll usually be somewhere between 1 and 2 hours after your meal.
Yeah. And and my experience was that I think I was instructed to test 4 times a day. And what about the timing of the fasting blood sugar test? Because, what are you supposed to do that the minute you wake up, or can you just potter around for a bit and go and brush your teeth and then do it? Does it make any difference?
I know where you're trying to go with this because I know your pregnancy story. So the guidelines, if we're talking guidelines, they're really not super specific about this. And I find it really varies practitioner to practitioner what they recommend. The goal for most people is that you're checking your blood sugar within 10 or so minutes of waking up, enough time that you've gotten out of bed and washed your hands at least, because you don't want any lotion or other things on your hands. You don't want dirty hands when you're checking your blood sugar. That could throw the reading off. But you do want to do it relatively quickly after waking up, because the longer you go after you wake up, and before eating, you'll start to have like hormonal compensatory mechanisms kick in to try to keep your blood sugar up for the day, right? You have a spike in cortisol, sometimes even before waking up, but often right upon waking up, that's going to try to raise your blood sugar to sustain you before you go and eat. This is just built into our physiology, but it's especially built in pregnancy as well, because you have the placental hormones on top of the normal cortisol surge that you have in the morning. So some people, if they wait too long before checking their fasting blood sugar, they'll find that it has actually shot up a bit. And for people who really get into it and get something like a continuous glucose monitor, you can actually sometimes see the spike very significantly on that.
That's really fascinating, because I've got to say, for pregnant women with gestational diabetes, I think if there's one hot topic, it's the fasting blood sugar, because it really is the toughest thing to manage in pregnancy. Extremely, extremely challenging. And, through interacting with women with gestational diabetes, I have come across people who went to extreme lengths to try and manage their fasting blood sugars, up to and including getting up in the middle of the night to down water and go on a treadmill, was one case that I heard about. So, just within the realms of like what is common sense to try, what are some things that a person might try to keep their fasting blood sugar below the target?
Well, this area, as far as evidence-based research goes, this is probably one of the most under-researched areas of gestational diabetes, is the management of fasting blood sugar. And I do want to point out that it's important to note that a lot of the information we have on fasting blood sugar and the goals that are set for fasting blood sugar are from like very large population-based studies where they're lumping people into various blood sugar control categories, not specifically and not only on fasting blood sugar, but also the post-meal blood sugar numbers.
Right.
And so I've come a long way in my understanding of, how strictly we should manage fasting blood sugar or not. When you start understanding like what is or isn't the evidence base behind really, really low fasting blood sugar. Because we do know, just in non-gestational diabetes pregnancies, fasting blood sugar tends to run really low in pregnancy, like 60s, 70s, maybe 80s.
I'm so jealous of those people. That was never me.
Right. And a lot of the guidelines are aiming for less than 90 or some less than 95. But there's a lot of question on whether for somebody who has excellent blood sugar control during the day, but their fasting blood sugar is, say, 92 or 96, should we really be freaking out so much about that?
And I have
number?
the urge to now try and translate these into millimoles per liter.
Yes, please.
I think, was it 20 to convert?
It's 18.
18. Okay, so you'd say they were aiming for sort of like under 96, you mentioned. Okay, 5.3. So that's what we're told here in the UK, in most places. It varies like slightly from hospital to hospital.
Divided by 18. 5.3.
5.3.
Yeah, and 90 would be 5.
So,
but to answer your question about what do you do for managing fasting blood sugars, I mean, there's a whole range of things you can try. And the most common recommendation is to try a nighttime snack before you go to sleep. And that's really coming from the fear that if you do not eat something right before bed and you're going a long period of time, the fear is that your blood sugar is going to dip too low and then have a rebound spike. Almost like, it's like the reverse of reactive hypoglycemia, maybe. And so the idea is that you want to like provide some sort of sustenance to like carry you over the course of the night. What I have come to observe though over the years is that when you have people check their blood sugar in the middle of the night, a lot of times their blood sugar is not dropping too low. And so I find it questionable how often we should really be doing the nighttime snack if the person is not hungry. If you're hungry, absolutely eat. I'm a big fan of mindful eating, eat. But should you be providing, say, a carbohydrate-based snack right before bed? If you're not a person whose blood sugar is dropping too low, I mean, should we really be trying to spike you higher? Because a lot of times when you have people test their blood sugar in the middle of the night, it's just sort of hanging out at a higher range. It's not dipping down too low.
Yeah.
So there's a whole range of things you can do. I mean, you can have a snack, you can not have a snack. You can play around with what you're actually having at that snack. You can play around with your dinner timing. Sometimes better blood sugar control over the course of the day improves fasting blood sugar. So there could be like a beneficial carryover effect. Same thing goes for exercise, because that tends to make you more insulin sensitive. Sometimes it's quality of sleep. And hey, if you have small kids in the house, like,
well, you can wave goodbye to that. Right? Yeah.
Good luck, because you're going to be woken up. I mean, mama too right here. I get it. There's also some micronutrients you can look into, like magnesium and vitamin D. There's some studies on inositol now. There are other areas that you can, definitely explore. Stress management. Some people find doing a meditation before bed, like they're just in a less stressed state overnight. Maybe they've brought their cortisol down. I don't know what the mechanism is, but that helps their fasting. It's a really like one of those situations where you kind of have to do a bit of trial and error to figure out what to try. And it's hard because you don't have all that much time to work on it. Oftentimes practitioners want to implement a treatment with medication or insulin within a week or two of observing elevated fasting blood sugar. So a lot of it depends on the practitioner you're with, how much wiggle room they want to get you, what the targets are, and it's tricky.
Yeah, I mean, in my case, I was told 3 readings out of the range in any context, and we're going in with medication. So, I would have had 3 nights to self-experiment. So I could have had inositol one night, apple cider vinegar the other night, maybe. I mean, that's another one that I've heard of. And, there wasn't a lot of wriggle room, but it's nice to, I mean, you can almost hear people just going mad trying to sort out the fasting blood sugar. And I think I reached a point where I just had to let go of it, where I was like, it's going to do what it's going to do. And, my story, which is that I more or less was getting high fasting blood sugars from practically day 1 of my second pregnancy. When I was obviously aware that I was at risk of gestational diabetes. And I was like, well, I'm not going to wait around to get the glucose test. I'm just going to see what's happening. So that was a frustration. But it was also although I couldn't control the fasting blood sugar and I just had to let that go. And I ended up going on long-acting nighttime insulin for that. One thing that did give me a lot of personal pleasure was, the only thing that I felt I did have control over was what I was eating during the day. And I took great delight in being given short-acting insulin at my first consultation, because they assumed that somebody who had a high fasting glucose from like almost 5 minutes after they got pregnant was going to need fast-acting. And so
absolutely,
it sat in my fridge and it expired, and I never needed it, not once.
There you go.
That was just, for me, was just, and that's not for everybody. I mean, not everybody is willing to make those changes to their diet and, or finds it enjoyable or tolerable. I mean, from my point of view, whether in pregnancy or out of pregnancy, I've just always felt better on low carb. Just because I'm not putting this substance into my body that it can't handle, and even going back to when I was in school or in college, after lunch, I would need to go to the library and have a nap. That was, this was me in my 20s. Yeah. So the writing was on the wall that, that something was wrong metabolically. I just didn't know it.
And what you're describing, I wanted to say, when you talked about what is gestational diabetes, notice we said first recognized or first develops during pregnancy. So sometimes there can be a pre-existing blood sugar issue usually like prediabetes or sometimes even full-blown type 2 diabetes that you don't know about. Because it takes your blood sugar getting pretty high for a really long time for you to actually like notice that there's a problem. I mean, and with pregnancy, when you're just being tested and there's a lower threshold for diagnosis, it just uncovers a lot of pre-existing blood sugar issues that may be mild or in some cases could be severe. And it's sort of up to us to, you know, take action on it or not. But in the case where your fasting blood sugar is elevated early on in pregnancy, that's usually a pretty good indication that there was some sort of blood sugar management thing going on beforehand. And yeah, it's probably going to be the case where your insulin sensitivity or insulin production won't be where it needs to be to manage this 100% food alone, right? And I see this a lot, where a lot of people can manage the post-meal blood sugars, their daytime blood sugars with food. But the fasting blood sugar might be that one stickler, you know? And I think it's sort of back to our earlier conversation about like, you know, to treat or not to treat. We have pretty good evidence that once you get to fasting blood sugar of 100 plus, and we should do the math on that, right? So 100 divided by 18 would be 5.555. So about 5.6. And above, you do want to be treating that, you know? And as you get much higher than that, it's like, you can try to, you know, food and lifestyle stuff. And in practice, we'd often give about 2 weeks. That was our clinic's policy. We'd give 2 weeks to see what you could do with food and lifestyle. And then we'd move on to some sort of a treatment. And, you know, I don't know, for the people who are like waking up to, you know, exercise in the middle of the night, I don't know if that's the healthier call. I think the healthier call might be getting a full night of sleep and having insulin.
Amen to that.
Right? I mean we can't pathologize medicine. It exists for a reason.
Each to their own, but especially in my second pregnancy, you know, there was no one who was going to take away that sleep from me because I knew I wasn't going to get it back for a really long time. So I was like, I love my bed. I'm willing to go to this certain lengths or whatever. We touched slightly on continuous monitors. I just wanted to touch back on that if that's possible. So are you seeing those coming in a little bit more now with the women that you're working with?
What's interesting, I think I must have like the most motivated people on the planet with gestational diabetes who seek out my course, because there's been, at least half a dozen in the group who have been able to get a continuous glucose monitor and use that. As part of their management strategy. So typically a doctor will just give you a glucometer that's like has a finger stick, and you poke your finger with a lancet, squeeze out a little drop of blood onto the test strip, and it gives you a reading. It's a one-time thing. And so you get 4 readings a day if you're doing fasting and after every meal. With a continuous glucose monitor, you have this little sensor that's attached somewhere on your body, usually on your arm, but some sensors can be attached in different places. And it has a tiny little microchip that's like sticking into your arm and your interstitial fluid, the fluid between your cells. And it measures.
It sounds horrific, doesn't it? But it's not actually as bad as it sounds.
It isn't. And I've worn a continuous glucose monitor. You can, if you search my blog for CGM experiment, you can read about my experience.
I remember that.
That was when I was not pregnant, but I did in my most recent pregnancy. I have a 6-month-old right now. In my most recent pregnancy, I did wear a CGM a couple times.
Congratulations, by the way.
Thank you. Yeah, I didn't write up a blog post about it. Who has time for that? With a baby?
I'm really amazed you have time for this, to be honest.
Babysitters. This is how anything gets done.
Yes, it's my life too.
But a lot of people are finding continuous glucose monitors really helpful because you don't have a single snapshot in time. You have, hundreds of readings over the course of the day that are then graphed on this nice little plot, and you can see exactly what happens with your blood sugar, when it spikes, how high it spikes. If you or catching the spike or catching the lowest point of it. You really see the full picture of what's happening inside of your body. So it's fascinating. It's definitely a new area. There are some studies on CGMs in pregnancy, but not many. So far, the studies show that they are an accurate alternative to doing a glucometer, although you do have to understand that interstitial fluid versus blood glucose. Yeah. Interstitial glucose and blood glucose, there's a delay in this sugar getting out of your bloodstream and into your cells. So it might not line up exactly with your finger sticks, but it does tend to be pretty close. So yeah.
So I bought one for my second GD pregnancy, almost like as soon as I took that finger prick test and I realized I had it, I was like, I'm going to buy myself a present to make myself feel better.
Now, wait, let me ask though, did you need a prescription or did you just buy it? Can you just buy it over the counter?
I think I just bought it. No, I didn't need a prescription.
See, in the US, you need a prescription. It's a big barrier.
Yeah. So I believe I don't want to be misquoted on this, but I believe, because obviously a lot of brain has gone since then with baby number 2.
The nature of kids.
But I believe I was just able to go on the Abbott website and order. I ordered a Freestyle Libre, and I was able to just get the sensors from my local pharmacy. In the UK, you could get a slight discount. You can get them tax-free if at the time you have a diagnosis of diabetes. So I was able to get the sensors slightly cheaper. It was still quite expensive to run, but for me,
that's amazing, because in the US you have to have a prescription, and it's often, unless you're working with a really proactive provider, it's hard to get a prescription.
Yeah, and that must be frustrating actually. Getting that extra bit of data. Have you had women that you're working with who've had some really surprising results that have kind of made them change the way they eat or do things?
Yeah, especially with the fasting blood sugar. So I have had people who were on the border of requiring medication, but they were people who had a significant spike, like a cortisol spike in the morning that drove their blood sugar up, but their blood sugar was actually averaging in the 70s or 80s overnight, low 80s. And it was like, whoa, look, right around the time my alarm goes off, I shoot up 10 points. So there have been cases where people have been able to avoid, medication or insulin entirely because of that. There have been times where people didn't realize, they're like, oh, my blood sugar is excellent after meals, but they were having reactive hypoglycemia. So their blood sugar would shoot up and then before the 1 hour mark and then crash. And I before having CGM, way back when I was in, clinical practice with a perinatologist, I remember having some people who would be like, my blood sugar is really excellent if I do just pasta and red sauce. But when I do the pasta and red sauce and have meatballs, it's worse by 20 points. And looking back now, it's like their post-meal blood sugar would be 70 or something. I was like, that's so interesting, crazy. I thought at the time, they're probably spiking and crashing, but it's really hard to give that explanation when you don't have CGM data. If I had had a CGM back then, oh my gosh.
Yeah, you would have seen it. And I when I was sort of frequenting the Facebook groups to get meal tips, you would occasionally come across somebody that said, I ate 3 donuts and my blood sugar was 3.5 after an hour. So you see, you people are all wrong. My donut diet is great. And, but then obviously they would do some
what that is showing to their defense. What that is showing is they still have a pretty massive pancreatic reserve function.
Lucky them, some of us don't.
Pump out big boluses of insulin. But is it a good thing? No, because your blood sugar still has to spike really, really high in order to get the signal for your body to pump out a bunch of insulin. And then because high blood sugar is so dangerous, your body is producing a little bit too much. It's like, whoa, get that blood sugar down as quickly as possible, and then you crash.
I think
Moreover, how do you feel?
Exactly. I don't think they felt great. I mean, maybe they felt good when they were having the donuts, but I mean, I remember when I was in my 20s, when I was in medical school, people used to make fun of me because when I decided it was time for lunch, I would start shaking and I would say to people, should we go for lunch? Should we go for lunch? Should we go for lunch now? Like, let's go now.
Yep.
Let's go. I was hangry and shaking, and I'm pretty sure that I was having some kind of reactive hypoglycemia from my standard Western diet breakfast.
I relate to that entirely. That was a big portion of my life, was reactive hypoglycemia. So for me, it's like I'm a fairly insulin sensitive person, so I can get away with more carbs than a lot of people. However, I feel better generally eating mostly low carb because your blood sugars are stable. I don't experience reactive hypoglycememia at all. But if I do, like in my CGM experiment post, I had the standard recommendation for a prenatal breakfast, which was oatmeal and milk and strawberries.
That's porridge to the British
porridge, exactly. And my blood sugar was a disaster. Was my body able to lower it back down within a reasonable amount of time? Yes. You wouldn't classify me as diabetic or pre-diabetic. However, I feel like garbage and I have reactive hypoglycemia for sure. And then you're just on a energy roller coaster, blood sugar roller coaster all day long. It's just not worth it to me to do it all that often.
And I definitely found that actually, that if you started the day with, like say if breakfast went a bit wrong when I had the gestational diabetes, then you were playing catch up all day. Then for the rest of the day, even if my, because I'd sometimes, I had the continuous monitor and I would also, maybe have a look and see what my blood sugar was before a meal. Even if it looked normal, it was almost like my body was just freaking out. And any carbs that I put in for the rest of the day, it would shoot up. It would, like the stress response was there.
I see that all the time. And even outside of gestational diabetes, just a non-pregnant nutrition client, I had like a saying, fix breakfast and everything else figures itself out. Because if you get people a solid breakfast that doesn't give them a huge blood sugar and then an insulin spike, so many other things just fall into place. It's like easier to choose like the quote right thing or the healthy option at lunch because you're not hangry. It's easier to forego the donut in the break room at 10 a.m. because you're not hungry, you're satisfied. It's like all of these things are just set up in your favor if you get that first meal right. I observe this time and time again.
Definitely. And there's just so much behavioral in food as well, and emotional. And pregnancy is a time of high emotion. You see other pregnant women, kind of like able to indulge in that and eat whatever they want. And I still remember after giving birth, I was in the hospital and I remember you saying, like, don't feel bad about this. But after the birth, I ordered a pizza and I drank orange juice and I got my husband to buy some mango. Like it was almost like I was like reacting like I have to absolutely
the carbs.
have all of the carbs. Obviously things have normalized now, but
well, I mean, and in your defense, that first month or so after birth, and depending on how strenuous or tiring or energy expending your labor was, I mean, there's room for replenishment, right? I wouldn't get super strict, but sometimes people, I see this a lot in the gestational diabetes groups, that people will sort of plan like, what is my first meal after pregnancy going to be, or my first treat? I think it's okay.
Well, once we're off the leash for, the first few days or months, that feels good. Well, thank you so much for joining me today. It really is it's been amazing just talking to you, and it's been a bit of a trip down memory lane for me as well. How can people find you? Like, what's the best way for people to find out more about what you do?
Well, you can find me at Lily Nichols RDN.com is my main website. I also have realfoodforgd.com. That's specifically for the gestational diabetes book and course. I do have a free video series over on that website. It's linked from both of those websites, so you'll find it if you go to the freebies tab. And that gives you just like the basics about like, oh crap, I've been diagnosed. What are a couple things I can do right now? Some of the history on gestational diabetes and and the, better dietary management strategies for
Mm-hmm.
it. That's also lilynicholsrdn.com is my main blog. So there's a lot of different posts on there. There's like 250 plus articles. If you want to read, say, the CGM experiment, just put CGM in the search bar and it'll pop right up over there.
Yeah.
If you want more information about the gestational diabetes course, you'll find that at realfoodforgd.com. That's one that you did. We welcome people from all over the world. And it's really awesome connecting with them because I feel like I already know you. We have a Facebook group for the course where I have office hours to answer questions directly. And a lot of times it's like figuring out the fasting blood sugar, what do I try next, sort of a thing, or managing healthcare providers that aren't on board. Some of it's about like communication strategies with your team, or what's your opinion on XYZ, or there's so many conversations in the group that are fascinating. And it's such like a well-read group. I mean, people are sharing research studies, and it keeps me on my toes. So that's really fun.
Yeah.
As far as social media, though, you can find me on mostly Instagram these days, and my handle's the same as my website. So Lily Nichols RDN.
Fantastic. Anybody considering pregnancy, interested in finding out more, who's been diagnosed with gestational diabetes, Lily really is the most incredible resource, and evidence-based on this lifestyle in pregnancy. So, absolutely recommend going and checking out all those resources, and, as an antidote really to the status quo and what you might find, in mainstream practice. So,
for sure.
It's been awesome talking to you. I knew this would happen. We have covered a fraction of the things that I would have liked to talk about, but it is such a massive topic.
Yeah.
I would love to have you come back in a few months' time to talk about some other things, intermittent fasting and breastfeeding and postnatal nutrition. There's so much to talk about. So
yes, I have a lot to say on those topics as well.
Wonderful. Well, thank you so much for your time. I'm really sorry that we ran over time.
Good.
I apologize.
No
you
worries.
go back to your little human and have a wonderful day.
Yes.